That's
Hello,
impressive, Mike.
And welcome to episode 149 of Public Interest Podcast with your host, Jordan Cooper, where we interview politicians, activists, advocates, and others who seek to improve the state of the world. We're here today with Dr. Michael Klag, Dean of the Johns Hopkins Bloomberg School of Public Health. He is a former commissioned officer for the United States Public Health Service. Mike is also a former Vice Dean for Clinical Investigation at the Johns Hopkins University School of Medicine. Incidentally, he's also a former graduate of the very school of which he is currently a dean. He is an internist and epidemiologist, noted for work on hypertension, kidney, and cardiovascular disease. He identified the correlation of those diseases with race, socioeconomic status, blood pressure, and diabetes for the first time. He is the author of over 200 publications. He's the founder of the Mike Klag Center for Autism and Developmental Disabilities. Quite an accomplished man. Mike, thank you so much for joining us today.
It's great to be here with you, Jordan.
So the first question I'd like to ask you is, what are you currently doing, or what have you ever done to advance the public interest, and why?
Well, I had a career in medicine, in clinical medicine, where I did a lot of research, and I think, I became convinced of the power of research to change the way that doctors think about disease, think about patients, and how we understand disease and how to treat it. So I think for many years that was my focus, and it had a great impact. For the last 12 years, I've been Dean of the School of Public Health, and it's a mission-based organization where we bring in bright young people, our faculty train them, and they go out and change the world. So we have programs in 130 countries, and I've been to most of those countries and trying to improve the infrastructure there for public health and for research.
And not only have you been to most of those countries, but isn't it true that under your deanship, you are responsible for expanding the reach of the Hopkins Bloomberg School of Public Health to many of those countries?
Yes, it's true, especially when it comes to educational initiatives. So in the 12 years I've been dean, we have established strong collaborations in China, Japan, the Middle East, and other countries, India, to improve the quality of education.
Why is that something that was important to you?
Well, I became dean in 2005. It was not long after 9/11, and it was much harder for students to come from around the world to our school to learn about public health. And you know public health well. It's about prevention. It's about understanding population burden of disease and risk factors for those diseases, and then designing interventions to improve health. So we, our school and our faculty, we're almost evangelical about public health education. We think that the more people who understand those principles, the better decisions society will make, and more people will be healthy. So we did a variety of outreach activities to improve education and establish ourselves as partners around the world.
So you've been a dean, and let's go back to the very beginning. You became a physician. Mm-hmm. Why is it that you became a physician? Were you one of the first individuals in your family to go to college, let alone medical school?
So my brothers and I were the first in our family to graduate from high school, and then my twin and I, we were the first in our nuclear family to go to college, and then we both ended up going to medical school.
There are many individuals around the world who may find that they come from a family that hasn't gone to college, just like yours, mm-hmm. and it doesn't seem to be something that they do, mm-hmm. right? College isn't for me. It wasn't. My dad got by and he didn't need it. Why do I think I'm better than him that I need to go to college? I think that may be something that a listener may be thinking. What is it was there anyone that inspired you, or how did you get the idea that not only should you graduate from high school and then you should go to college and graduate from there, but that wouldn't even be enough. You'd have to go to medical school.
Well, my parents were frustrated that they had not been able to graduate from high school because of economic reasons. They had to go to work. So from the time we went to first grade, they emphasized the importance of education. So it's a primary thing in our lives, and we were taught from an early age to work hard at school. Then they wanted us to go to college, but they didn't really understand what college was. So when we got to college, I thought I would be a high school biology teacher, but everybody in my classes was pre-med. So I got a job one summer working in a hospital to see if I liked it, and I did. And when I went back to school, my twin brother took the job. And so then he decided to go to medical school as well.
So you both became physicians.
Yep.
And yet you say that a great bulk of your career has been shaped by research, involvement in work in public health, which is to say, as the school's motto is, saving lives millions at a time. So you were trained to be a physician to save lives one at a time. How did you make that transition to public health?
Well, when I came to Hopkins in 1984, I did so to learn how to do clinical research. And the way you design good clinical research is to understand epidemiology and biostatistics. You know, how you design studies, how you collect data, how you present the data, how you analyze it, how you make inferences. And when I came here, I didn't know whether I wanted to do research. I wanted to learn about it, but found that I loved it. And so coming to Hopkins changed my life. And then, as I said earlier, when you do research, it can have a huge impact on the health of people. So even though I was seeing patients one at a time, I knew my research was influencing a much larger number of patients.
And yet it must have been frustrating to learn that it often takes 17 years from research to go from bench into practice. So you're doing things that you think could potentially save lives. If only we gave these tablets to children in Bangladesh, then they wouldn't die of dehydration when they have cholera, and yet they continue to die. Or if only we had mosquito nets and they wouldn't die of malaria, but yet this data wasn't being translated into actual lives saved. Did that have an influence on your life?
Well, I think there are several translational blocks, as they're called. One is from the laboratory to getting a new drug, a new therapy into humans, and then once you know it works, how it gets out to the broader community and used in patients. For the kind of work I did, I thought I would do clinical trials, but it was primarily observational studies, so large cohorts, looking at risk factors for kidney disease, seeing who did well in dialysis, who did not. And because that kind of work just had not been done, it had impact in a very short time frame because it was really new information. I think your points about translational blocks are a good one, and much of what we do now at the school is to take knowledge that we already know and figure out ways to implement it better. And implementation research is now become its own field, and many of us here at the school work on it.
So implementation research, but you're an epidemiologist. For those our listeners may not know, what is an epidemiologist?
Well, epidemics comes from this sense of infectious disease that come into a population, infect a large number of people, and then hopefully people become immune and the disease goes away. So it was set up to study infectious disease outbreaks. But those techniques, identifying what a case is, coming up with criteria for the case, and then methods of detection, and making sure that you collect information in an unbiased way. 50 years ago, they started to be applied to chronic disease, to cancer and respiratory disease. Cigarette smoking is a risk factor for cancer. It came out of epidemiologic studies. And so I learned epidemiology not so much to study infectious diseases, but non-communicable diseases like cardiovascular disease and kidney disease.
And now chronic diseases present some of the greatest burdens, health burdens, to the developed world writ large. Is that correct?
Yeah, almost 2/3 of the people in the world die from non-communicable diseases.
So, well, of course, someone may say, well, you have to die of something, right?
Yes.
So if you're going to do a lot of work in giving beta blockers to prevent heart attacks, and maybe you're going to die of cancer, eventually we have to die of something. How do you, I guess, what is the goal there? Are we looking just to prolong life? Are we looking, because there's no way to cure cancer or to cure heart attacks, right? Eventually something has to fail.
Well, so obviously we want people to live a healthy life for as long as they live. And much of what we try to do in public health is prevent disease. And so certainly, at an advanced age, people die, but many people die early in life. So the good news, the reason why people are dying of non-communicable diseases is because we've done a pretty good job. We need to do better, but a pretty good job of reducing under 5 mortality, of childhood mortality, through mainly through vaccinations and improvement in water and nutrition. So now people are surviving longer, and we have a new problem to deal with. But it's a problem where we know we can have an impact by reducing smoking, for example, by making sure people eat a healthy diet and stay active.
So it sounds like that chronic disease are challenges posed by chronic disease is actually a problem associated with our success in public health in reducing communicable diseases.
That's right.
I'd like to go back to the beginning with your seminal work, and I believe it was China, where you worked on blood pressure and you began really attacking as an epidemiologist for the first time some of the chronic diseases associated with hypertension and kidney disease. Can you speak about how you ended up in China and what you were doing?
So that's a great example of the difference between clinical medicine and public health. So I was a physician treating patients with high blood pressure, finding them, by measuring their blood pressure in clinic and then treating them. And at the same time, I was a faculty member here in the School of Public Health, and one of my first graduate students is a man named John He, who came from China. And he was interested in blood pressure in different populations and had done a study called the Yi migrant study. Yi is an ethnic group in China, showing that these folks who were subsistence farmers living up high in the mountains, they did not have high blood pressure, whereas a quarter of the people in America and Han people in China have high blood pressure. The question was why. And through a number of studies, what we found is that the people who moved down to urban centers, they got a blood pressure profile just like the Han population ours. A quarter of them had high blood pressure, and it was due to eating more salt, more processed food, being less active, being a little bit heavier, and drinking more alcohol. And so those then became pieces of information that I could use in my practice to advise my patients about how to reduce their blood pressure. And then we took those findings and they became the basis for a number of clinical trials in the U.S. showing that implementing interventions to, say, reduce salt intake could lower people's blood pressure.
Now, we're all dealing with probabilities, right? Because there will be inevitably a listener who says, my grandpa lived to 100 and he drank whiskey and smoked 2 cigars every day.
Yeah, Winston Churchill. It could be Winston Churchill. Well, it's true that there's a spectrum of susceptibility to these chronic diseases. So, for example, we know that people of Asian heritage are much more likely to get diabetes than somebody who's got a Caucasian Western European genome. They have a number of they have a number of genes, each having a small effect, but that increase the risk. So, there's this environmental gene mismatch, right? And some people can get away with unhealthy behaviors and not have harmful effects. But on average, we're measuring the average effects. On average, things like cigarette smoking, eating too much salt, eating not enough fruits and vegetables, it's unhealthy for people.
So it sounds like a lot of what your work did is associated, chronic disease with behavioral factors and environmental factors that increase your risk of getting those chronic disease and therefore increase your risk of having a shortened lifespan. And that you can follow this and eat minimal salt and lose your weight, abstain from alcohol, be active, and you can still die young, potentially of a chronic disease, but it reduces your probability. And if a whole population does that, then on a population level, you'll see a decrease in the chronic disease. Is that
That's true. And even if the effect is small for any individual, if you accumulate that across a whole state or a whole city or a whole population, the health effect is huge.
Yeah. So you're doing work over in China, you're working on chronic disease, and of course, in your current role, you are the administrator of of the premier public health school in the world. And a lot of your work has to do with fomenting international collaboration, with fundraising. Of course, you brought plenty of donations with relationships with famous individuals like Michael Bloomberg or with Microsoft.
The Gates Foundation has been very generous.
Bill Gates.
So,
So, but that's not actually. You're fulfilling the mission, but in a different way, right?
Yeah.
Because you're not actively engaged in research. Can you speak a little bit about how? Because you said you enjoy your role as dean.
Yeah, I do. So my job is to be the spokesperson for the school, to set the vision, and to facilitate the success of our faculty in the school. So when people ask me what work do, I think of work as research and writing papers and grants. I say, I don't actually do work. I help other people do work. And so we try to create an environment where people can be productive and where they can have access to resources to tackle big problems and find solutions.
How do you, so I guess I'm interested in the story of how you identify a funding source and then identify a mission or a center. I want to take the very poignant and personal example of the Wendy Klag Center for Autism and Developmental Disabilities as a means of not only understanding your job here, but more importantly, understanding who you are and how your perspective is shaped in public health. You created this center. I'd like to ask you to speak about what led to creating this center and I guess how that fits within the School of Public Health and what it's been able to accomplish today.
So when my daughter Sarah was 5 years old, she was diagnosed as having autism. And at the time, I was heavily involved in research. I looked at the literature on autism and risk factors. And this was 21 years ago. The quality and the breadth of the research was not what it should be. And most of the work was done because that we knew that autism had a high heritability. It ran in families. Most of the work was done on genes and linkage studies. But what's happened since then is we've seen a marked increase in the prevalence of autism. And some of that is due to reclassification of people who used to be called another condition, now are labeled as autism. We don't know how much is a true increase in incidence, but there's some data that suggests there's also a true increase in incidence. So I was always interested in relating to people who did research in autism. I taught for 20 plus years a summer course in clinical research methods and recruiting people who worked in autism. And then my wife, Wendy, my first wife, devoted her life to helping Sarah to succeed. Basically reteaching her every night so she could get through school, and just put an incredible amount of effort. And unfortunately, Wendy died suddenly a year after I became dean. We had 3 children. And at the time, we established a scholarship in Wendy's name to give small amounts of money to students to work on issues related to autism, leveraging other resources that we have at the school, international and national studies on children. And then about 5 years ago, we started the Wendy Klag Center to recognize her memory and to acknowledge all that she was just a role model for people who care about children, especially children with autism. So we founded the center in her name, and the idea is to bring the strength of public health to the study of autism and developmental disorders. So if you look at autism, it's clear that it's not all genetic. So we need to work with people who understand not only genes, but the environment and environmental exposures. We need to work with providers like our colleagues at Kennedy Krieger Institute and our School of Medicine here who work with children with autism to get their clinical insights. And then there are just huge policy implications. So my daughter is on the leading edge of a generation of an avalanche of kids with autism, and will they receive entitlement benefits through Medicaid, Medicare? How do you provide services for them? So it's really a way to bring together the strength of everything we do at our school with our colleagues at KKI and the School of Medicine to work on this problem of autism from multiple facets.
It sounds like a lot of what you're trying to do in creating this center and other centers is create opportunities to shine more light and more attention on issues that otherwise aren't being explored. And a lot of what you do is create new opportunities, as you mentioned, for students and faculty to pay attention to these different areas.
And to work together.
Collaboratively. Of course, you're increasing a number of faculty that have multiple appointments in different departments across the school and across different schools on the Hopkins East Baltimore campus. So, I guess it's interesting. You're a former student here.
Right.
And also you do currently hold and have held different appointments in various schools and various departments. You speak about policy. There's a department here, health policy and management, but of course you went through the epidemiology department. I'm wondering if you can speak for a moment just about how your experience as a student here has informed some of your work that you've done as dean in distributing grants to facilitate more research by students, and also having come up through epidemiology specific lens, you now are, as dean, focused on all the different departments and on health policy and on the Congress and the state legislature, and I guess how that melange solidifies for the school.
So I came to the school to learn how to do research and focus on epidemiology, but as part of that Master's of Public Health degree program, I was required to take courses in environmental health, in health behavior, and health policy. I hated taking them. It's not what I wanted to do. I only had.
You didn't change the requirement as dean.
No, but I have to say, those were the courses that changed the way I thought and gave me an incredibly broad outlook on health. Before that, I saw health as really primarily what happened in a physician's office. Mm-hmm. Then I learned about the social determinants of health, about how policies can influence health, mm-hmm. And that many times the biggest factors that drive health aren't healthcare. They're education, income, where you live, what you're exposed to.
Something like 60% of attributes, 60% of those things that affect a person's health is actually attributable to non-healthcare related things, such as behavior and diet and environment, right?
Well, there's several ways people have tried to look at that. One is there's been a marked fall in coronary heart disease since 1968 in the U.S. And people have tried here in the U.S. and other places to partial out how much of that is due to healthcare. Mm-hmm. And it's usually about 50-50. 50% of the reduction in mortality is healthcare, 50% is improved lifestyle, reduction in risk factors, prevention of disease.
So I want to speak now about what really makes you feel alive in this job. Mm-hmm. You told me once that you have many other opportunities that you might have been able to pursue in the last dozen years, but you've always chosen to stay here because this job has suited you so well, and you really are happy when you wake up in the morning. Yeah. Why?
Well, I think there's not many things you do where you come to work and you're inspired by the faculty and the students and the staff and know that what they do makes the world a better place. I come to work and I find out every day something new about projects that we have in Baltimore or Maryland or around the world. And it makes me feel better about the future of the human race.
It also seems like a pretty exciting job. I mean, you meet Bill Gates and Michael Bloomberg, you go do business in Singapore and Abu Dhabi, you get to meet sheiks.
Well, actually, it's Melinda Gates who I've worked with the most. And I've been in the same room with Bill Gates, but never really related to him. But yeah, it's true. It's, when you become head of an organization, mm-hmm. That brings with it pluses and minuses. For this organization, it's primarily a plus. But because of the work of our faculty and our students and our staff, I get entree to ministers of health and to great people all over the world. People who care about public health are great people. They're altruistic. They understand data, and they want to do something that's going to increase opportunities for people and improve their health.
So you're about to leave your position as dean. Clearly, you're not going to leave the field of public health, but you're taking a sabbatical. I don't want to ask about what's coming next, mm-hmm. but what I do want to ask is, you've had so many different chapters in your life, so many, just an incredible array of titles and positions, and you've really an impressive resume. What is it that leads one to conclude that it's time to move on to another chapter, especially when you found a position that seems to be, you could have sat in this role for decades. What is it that you're like, this is really what fits? This is my calling. I'm a great dean of public health at the best school of public health in the world. I've reached where I want to be. This is my goal. And then somehow you realize, it's time to pass on the baton to the next leader. How does one ever come to the idea, to conclusion that it's time to step back and move on?
Well, so I'm 64, and I'll be 65 when I step down, and I'll have served for 12 years. I think it just seemed like the perfect time to step down because we've had our issues with the decreasing federal budget, and resource issues. Well, I don't know. We haven't really. Do you edit this?
No. You've been very successful at bringing in, I think it was $1 billion.
Yeah, so here's why I felt it was the right time to step down. The NIH budget which is our primary funder, had mm-hmm. increased over the last 2 years. It looked like it was going to continue to rise. Mm-hmm. We have educational innovation like never before. We're offering a whole new series of online degrees, and we're teaching, as I said, in partnership in India, in China, in Japan.
You've left your mark here.
Yeah. We just have. It just seemed everything is going really well, and so I thought this was the time to hand it over to somebody else, right? When things are going really well.
So we are approaching the end of the podcast.
Oh, and I should mention the $300 million gift, you're right, from Bloomberg Philanthropies to take on these incredibly pressing problems in the U.S. It's our first big gift for domestic public health, and we're really excited about it.
And it's a very similar size to the gift that the same man previously gave that resulted in the school being named after him.
So the naming gift was $30 million.
And this was $300 million.
300
10
million.
times larger.
Yes, but Mike also contributed greatly to our Malaria Research Institute.
Interesting. All right,
totally, he's given $600 million plus to the school.
An amazing demonstration of altruism, as you say, which is so prevalent within the field of public health. As we approach the end of this podcast, and I ask you a final question, I'd like you to suppose that you're standing before the MPH class, perhaps at Meyerhoff Hall, as they graduate in a few months. And I'd like you to speak to them and talk about the importance of what their public health education means. Why is it so important? Why have you done what you've done? Why is it so important to commit yourself to this field in particular? And what, at the end of the day, not only do you hope you will have accomplished through your life and your work in public health, but what would you hope that would be their legacy through their efforts? What do you hope that they would accomplish throughout the course of their lifetime?
Well, I know what they will do because they've been doing it. You've been doing it, and our other graduates, they go out and change the world. And they may change it in Bangladesh or Baltimore, but they attack problems that affect large groups of people. Sometimes those problems are behavioral. Sometimes they're policy interventions that need to be done. But they make the world a better place. They improve the health of millions of people all over the world.
And that has been Mike Klag, the Dean of Johns Hopkins Bloomberg School of Public Health, a former commissioned officer in the United States Public Health Service, the former Vice Dean for Clinical Investigation at the Hopkins School of Medicine, former graduate of the Johns Hopkins Bloomberg School of Public Health, an internist and epidemiologist. For our listeners, those are both physician roles. And he's the author of over 200 publications, founder of the Wendy Klag Center for Autism and Developmental Disabilities. Mike speaks about public health as a means of doing the most good with the resources that you have at the time that you're around. Maximizing output to really, basically maximizing altruistic output seems to be a way that Mike views the world. That to save lives one at a time as a physician is well and good, and to work on policy is well and good, and there's so many people who are taking so many different tacks to try to improve the world. But the thing about his life in public health is that he's come to realize that advancing the state of public health is the best way that he knows how to improve the most lives as quickly as possible. He's saved lives, as concretely has enabled individuals who wouldn't be alive today to survive beyond, on a statistical level, mortality that they surely would have met. Mike has been through many different roles and finds that motivation he finds himself motivated by what is public health and his service to public health and is fulfilling for him. His role as dean is one that enables him to work within the field of education, public health. He builds relationships, and he's left a legacy. Through his work, he's been able to create centers, bring in funds, create new relationships, new partnerships with other countries, make educational opportunities available to people all over the world. For Mike, it's all worthwhile to advance the public interest through public health, because at the end of the day, he's saving lives and enabling them to be healthy enough to pursue their own interests and actualize their potential. And that's what public service is all about. So Mike, I'd like to thank you so much for joining us today.
Well, thank you, Jordan. It was great talking to you.
And this has been episode 149 of Public Interest Podcast with your host, Jordan Cooper, where we interview politicians, activists, advocates, and others who seek to improve the state of the world. I remind you to subscribe at publicinterestpodcast.com, listen on iTunes, Stitcher, SoundCloud, Blueberry, Player FM, Facebook, Twitter, or LinkedIn. Should you wish to contact Mike, you can call 240-630-0380. Leave a voicemail, and that will be emailed to him. Thank you so much for listening. We'll talk to you next time.